So, hi everyone, the class of 2024, class of 2023, year 4. Okay, so I'm back with the second part of the lecture, that is Principles and Practice of Impression Procedures, Border Molding and Final Impression in Removable Dentures. So, as you would remember, in the first part of this lecture, we had covered principles and practices of impression making, that is preliminary impression and the preparation of the diagnostic cast. So, the topic today is in continuation. Today, we will discuss the principles and practice of border molding and final impression for complete dentures. Moving on to the learning objectives, you should be able to explain the bottom molding and final impression, what it is. You should be able to categorize the bottom molding materials, the secondary impression or final impression materials, as well as the techniques. You should be able to compare between a single step and incremental step bottom molding. And you should be able to describe the importance of posterior palatal seed. You should select the appropriate material and technique for the impression of compromised ridges such as flabby ridges, inflamed ridges, and ridges with undercuts, etc. Moving on. Now, the steps in the fabrication of complete denture, as I'm sure most of you must be knowing who have started or taken up cases for complete dentures. That is, the first step is the selection of a stock tray. The second step is the making of the preliminary impression or the diagnostic impression, followed by the pouring of the diagnostic cast, followed by special tray, that is a custom tray fabrication for making the secondary impression or the final impression, which is followed by the pouring of the master cast, and then the denture steps begin. Denture fabrication, that is, you first fabricate the record base in the occlusal rims, then you do the tooth setting and the jaw relation. Now, this is followed by articulation of the wax rims that has after the maxillomandibular relationship. After this, teeth setting is done in the laboratory, which is followed by a wax trying in the patient's mouth, and any adjustments are which may be needed are done at the time chairside. This is followed by waxing, flasking, followed by dewaxing, and the acrylization of the complete dentures. After this, the dentures are divested, they are trimmed and polished, and the denture insertion is done, which is the last appointment. Next, so this here today we'll be dealing with the steps, principles, and techniques of fabrication of custom tray, the bottom molding, the final impression, etc. So, what is a special tray? A special tray is a custom made device prepared for the particular patient, which is used to carry, confine, and control the final impression material while making the impression in the patient's mouth. So why do we need a special tray? We need a special tray to support the green stick compound, that is to do the border tracing, and then to make a final impression of the denture bearing area. And the special tray ensures that we get an even thickness of the impression material all throughout the denture bearing area so that we get an accurate impression. The requirements of a special tray or a custom tray are: it should be well adapted to the primary cast, there should be a uniform 2 mm thickness in the palatal areas, lingual flanges, and all the flanges all around. A 2 mm relief should be provided under the custom tray, and it should be free of voids and projections in the tissue surface area. So, what are the various materials used for fabrication of custom tray? We can use self-cure resin, or also known as cold cure resin, which is most widely used all around. We can also use polystyrene, which is a type of polyethylene material or plastic material. Here at PIDC, as you all know, we use light cured resin sheets, that is light cured composite resin sheets, for the fabrication of the custom tray as well as for the fabrication of record bases. So moving on, after the diagnostic cast has been poured, it is trimmed. Base is, and you should ensure that it has a flat base, a proper land area, and then the diagnostic cast is relieved of any irregularities, voids, or projections. Then it is soaked in water. Then the outline of the sulcus, the special tray outline, and the outline of the wax spacer is drawn onto the diagnostic cast. This is followed by making of the wax spacer, and over this the custom tray is prepared. So why do we need a wax spacer? As most of you must be aware, the tissues we should be recorded in a state of anatomical rest. That is, we use what you call as a selective pressure impression technique. That is, the areas of the denture bearing tissue that can take the load of the mastication, they are not relieved, and the areas of the tissues, and the relieving structures or the limiting structures such as buccal frenum, labial frenum, and the lingual frenum, and the limiting structures basically need to be relieved. This is done by providing a wax spacer and ensuring that a custom tray does not impinge on the limiting and relieving structures in the patient's mouth. So a spacer is made with a modeling wax or a base plate wax, and it should have a uniform 2 mm thickness. So as we have already discussed the materials used for the fabrication of custom tray. When it comes to the self cure or the cold cure acrylic, that is polymethyl methacrylate, these are the different techniques that can be used. We can use a sprinkle on technique, that is a salt pepper technique, in which we sprinkle the self cure resin powder and we pour tiny drops of monomer over it. This is the most accurate and the most precise method of making custom tray because it has intimate adaptation. The second and more easier technique is a dough technique, in which we mix the monomer and powder in a 1:1 ratio in a dampened dish or in a silicone bowl, and then it is allowed to bench cure till it passes through the various stages such as the stingy stage, the sandy stage, and then the dough stage. And in the dough stage, it is rolled out into a thin sheet and then adapted over the diagnostic cast. And the third technique is, in case of a light cured resin material, we use a UV box to cure the resin material. So this is how we do in our lab. Of course, this is a blue colored resin sheets. In our lab, we have pink colored LC resin sheets. So this a sheet is taken, it is adapted over the denture bearing area and over the wax spacer. And after intimate adaptation, a handle is made over it, and then it is cured in a UV box. So, as I mentioned, you should make the tray, and then over it a handle is placed in the usually in the anterior region. The handle should be at least 3 mm thick in width and should be at least 8 mm high. The handle should be parallel to the long axis of the teeth. That is, in the maxillary anterior, it should be slightly slanted at a 15 to 20 degree angle. In the mandibular anterior region, the handle should be straight, projecting straight upwards. We can also make accessory handles over the molar area to stabilize the tray during the impression making. So this was the steps in the fabrication of a custom tray. So here we can see in a nutshell the diagnostic cast, the wax spacers are made, the undercuts are blocked out, and the special tray is fabricated over the diagnostic. So next, coming to the making of a secondary impression, the first step in secondary impression is border tracing or border molding using green stick impression compound. This can be done in increments, that is to record one label sulcus of one side and the buccal sulcus of the same side. Then you go to the contralateral side, record the label sulcus first, then the buccal sulcus and the posterior palatal seal. All it can be done in a one shot. This is usually one shot border tracing is done when you are using elastomeric materials for making border molding. After border molding, a wash impression is taken usually with a zinc oxide eugenol or with a sorry, here it's written light body silicone. You use regular body or medium body silicone material or medium body polyether material to make the impression. So next is the recording of the posterior palatal seal. In the posterior palatal seal, the soft tissues along the junction of the hard and soft palate on which pressure within physiological limits can be applied are recorded. This will aid in the retention of the denture. So we can use a conventional approach, that is, we ask the patient to say short and long ah, and the visibly the movement of the hard and soft palate is recorded and the tray is trimmed, or we can use mouth temperature wax which is applied over the postpalatal seal area, and the patient is asked to do various movements such as swallowing, opening the mouth wide, etc. And this will record or in the postpalatal seal area in a functional state. The third is the least favorable but still does the trick, that is arbitrary staking of the master cast. That is, on the master cast we scrape the postpalatal seal area to a certain depth. before the acquisition of the denture. Then coming to the first step, that is after fabrication of the border tray, that is the border molding or border tracing. So this is done usually with impression compound, which is a thermoplastic impression material. In this case, a green stick impression compound is used, or as I mentioned, it can also be done using elastomeric such as silicone or polyether based impression materials. That is usually it is available in the putty consistency, and this can be done incrementally or in one go, but usually making bottom molding with silicone based putty materials is not advisable, and it does not record the tissues in a functional state. It always results in an overextended denture borders and will compromise the retention. So you have to be pretty very skillful and very quick in making bottom molding using an elastomeric impression material. So here are the materials. Usually, generally we use low fusing green stick compound. These are some example of it. It is tempered in a water bath at 70 to 90 degrees centigrade and then adapted over the borders of the denture, and then the operator does the various functional movements for the patient to record the limiting structures. And as I mentioned, we can also use polyvalent siloxane or polyether. Another example is isofunctional compound sticks from GC, which are also like green stick compounds and also used for border tracing. So border molding of the labial sulcus is first done in the region of the labial sulcus, that is the upper lip is elevated, extended outwards and then pulled downwards repeatedly to record the labial freedom and the labial vestibule, that is orbicularis oris muscle around the lips and levator anguli superioris. And this procedure is repeated until we are sure that we have recorded the labial frenum and the labial vestibules in the proper state. Then the buccal vestibule or the buccal sulcus is recorded. Again, here the cheeks are elevated, pulled outwards, downwards, and inwards to record the buccal frenum and the buccal vestibule. Also, the patient is made to open wide, and side to side movements are done to record the coronoid notch and the width of the labial vestibule. After this, the same is repeated for the contralateral side, and the last step is the recording of the posterior palatal seal. Softened compound is placed at the posterior border of the custom tray. That is, first the custom tray is trimmed by visibly marking the junction of the hard and soft in the patient's mouth. Once we are sure of the extension of the custom tray or the special tray, after that the softened compound is placed in the posterior palatal seal area, and the functional movements such as swallowing, tilting the head is done by the patient opening wide to record the posterior palatal seal as well as the pterygomandibular raphe in a functional state. And then the using a tape burnisher, the posterior palatal seal is marked in the patient's mouth, and then this is transferred to the impression. That is after you make the zinc oxygen on impression. So next, coming to the bottom molding in the mandible, more or less essentially the steps for bottom molding are same as those in the maxilla. But in this case, when we're recording the buccal frenum and the buccal vestibule, patient is asked to open widely, and then operator pushes the mandible down and asks the patient to close. So this will activate the elevator muscle, that is the masseter, which is the strongest of all the elevator muscles. In the masseter muscle, when activated, it pushes inwards the buccinator muscle, and this will create a masseteric notch just lateral to the retromolar pad and superior to the buccal shelf area. And in case of mandible, we also have to record the lingual phalanx, the lingual frenum, the alveolingual sulcus. So all these movements are done by asking the patient to protrude the tongue by touching his tongue to on upper lip to the corners of the mouth. So this will record the essentially the alveolingual sulcus. And then the tray is prepped before making the final impression with zinc oxide, eugenol, or any final impression material of your choice. The wax spaces are removed to create space for the final impression material, and then holes are made on the denture bearing surface of the or the basal sheet area of the tray to create relief holes for the excess impression material to come out, and to avoid putting excessive pressure on relieving structures such as incisive papillae, the mid palatine foramen, and the Rogi. So next, as coming to the importance of posterior parietal seal, because this is one of the objectives of the learning outcomes. The primary purpose of posterior parietal seal is to create a suction or a negative vacuum within the denture and to retain the maxillary denture. So this is imperative that you record the posterior parietal seal very accurately. Other advantage of posterior parietal seal is that it prevents the food from or food ingress inside the denture. So this keeps the denture clean and keeps the patient comfortable. Also, posterior parietal seal accurately recording it will reduce or eliminate any kind of gag reflex that the patient may experience, and it also to a certain extent acts as a stress bearing area within the physiological limit. So this is a secondary impression. This is how a secondary impression should look. It should be an exact or accurate negative likeness of the denture bearing area or the denture that is being fabricated. It should record all the final details such as labial frenum, the buccal frenum, the rugae, incisive papillae, mid-palatine foramen, the ridges, all the stops should, that is all the four stops should get exposed. Here you can see all the three tissue stops getting exposed, and the fourth one is faintly visible over here, and we should get a wash impression, that is you should be able to see the green stick compound. This was an impression which I took probably a week or 10 days back for one of the final year students. I did the bottom molding and the final impression for them because they were struggling here, but you can see here green stick is extending onto the tissue surface area. This should not happen. Any green stick extending over the spacer area should be removed with a sharp PP blade or a scalpel blade. So this is one of the this shortcomings, but overall this is a good impression with no voids, no porosities, accurate recording of all the borders. You should not only record the border extension, but you should also record the width of the denture flange or the width of the border molding, so that you get an accurate impression and a guide for the final denture. So second impressions, as I mentioned, can be made using a zinc oxide eugenol impression paste, which is a very accurate material for recording denture-based final impressions. Although it has one disadvantage, that it is messy and it is brittle and may break or crack in the undercut, such as bilateral tubular toxicity undercuts or the exostosis or the tori. Another material which can be used for making final impressions is Reprosil, which is a regular body or the medium body silicone impression material, which is also known as Monophase and marketed as another brand is Imprint Monophase. And we can also use polyether monophase, that is medium body impression material, using impregnum self-dispensing guns to make a final impression, since polyether is also a very accurate impression material. So now coming to the requirements of an impression, how do you know that the impression that you have recorded is useful or it is a good impression? The impression should be free of any voids, which can be rectified by wax, and then it should extend to the entire vestibule. As I mentioned, it should record the width and height of the vestibule and the limiting and the relieving structures. After this, the impression material needs to be sterilized. It's usually done using iodophores or glutaraldehyde by spraying the impression for 10 minutes. Now, these are in a nutshell. This is how a special tray is fabricated, bottom molding is done, and then final impression is taken and the impression is put. Of course, these are pictures taken from the internet. This is now not how an accurate impression should be, but you can see here how the posterior parietal seal is recorded using mount temperature or fluid wax. But as you can see, none of the stops are exposed in this area. So this is how final impression will look with the zinc oxide eugenol, and on the left we have a final impression which is taken with a medium body silicone impression material. So now after the impression has been made, beading and boxing is done using beading wax and what you call modeling wax, and then the impression is poured with a type 3 dental stone. After this, the master cast is obtained. You should have uniform land area of 3 to 4 mm all around the master cast to call it a good master cast. And then coming to the special impression techniques for the compromised ridges. Like I mentioned, when your patient has flabby ridges, which will usually be the case in case of the maxillary premaxilla or the mandibular anterior region, tray small windows are made in the special tray over the flabby ridges or the hyperplastic ridges so that these tissues can be recorded in a what you call an in their anatomic state and not in the functional state, because they will get distorted if we pressure is applied over them. In case of severely resolved ridges, we can use a neutral zone impression technique in which mouth temperature boxes are used and patient does functional movements to record the impression.